named Columbia at one point. But in the 18 years that I've been with the practice, we've expanded our services to now 10 inpatient centers and multiple clinics. Augusta is the largest burn center in the country. We currently have 72 beds and are opening a burn tower later this year. So super excited for that, and happy to answer any questions that any of you may have about that at the end. So when we look at burn injuries, there are over 1 million burn injuries every year. So it's about 1 every 23 minutes, and there are over 50,000 hospitalizations for burn injuries each year. The cost is astronomical. When we think about burn injuries and why do they cost so much, we think about the extended hospitalization as well as the surgeries and specialty dressings that we use for these patients, because we are keeping patients alive longer, and we're actually have a lower mortality rate with our bigger burn injuries. The cost for burn care continues to increase. Each year there are about 4,000 deaths. 75% of those occur at the scene. So if you think about from a scene standpoint, we primarily think of inhalation injury with carbon monoxide and cyanide toxicity, as well as electrical injuries. Those are the common causes of death at the scene. So the basic adage is that if you make it to the hospital, you've got a pretty good chance of survival. So when we look at the demographics, so we say who gets burned. Most common cause of burns in adults is the flame injury, and children is a scald injury. So both of those are thermal, but about 67% of the burn injuries are in men, and about 60% are Caucasian. 74% in the home, with the kitchen being the #1 room in the home where patients sustain a burn injury. And you can see the average age, 32 years. In our network, the oldest patient we've treated was 105 years old, and the youngest patient was 2 days old. So when we look at kids specifically, there are about 116,000 children that suffer some type of burn injury each year. About 20,000 are admitted to burn centers. 1,000 die each year because of burn injuries, and those are primarily in house fires. And 70% of pediatric burns are caused by hot liquids. So again, your scald injury. And burns are the third leading cause of accidental death and injury in children. So the American Burn Association is our national body, and they govern burn centers across the country, provide burn verification, and they have set aside 10 criteria for transfer or referral to a burn center. So just looking at these referral criteria real quickly, any burn that is greater than or equal to 10% total body surface area. The second is any burn involving the face, hands, feet, genitalia, perineum, or major joint. The reason for that is function and cosmetics. The third criteria is any third-degree burn, and that's because most third-degree burns require skin grafting in order to heal appropriately. Fourth criteria is any chemical burns, and fifth is electrical burns. Those are a completely different pathophysiology than the thermal injuries, but treated in burn centers also. The sixth criteria for referral to a burn center is an inhalation injury. When we think about inhalation injury, we think primarily about carbon monoxide poisoning. We also think about cyanide toxicity. We think about chemical inhalation, and patients can have an inhalation injury with no cutaneous injury and still meet criteria for referral to a burn center. Seventh criteria for referral is any burns in patients with pre-existing medical disorders. The eighth is burns involving concomitant trauma in which the burn poses the greatest risk of death. And we already said that the patients who die primarily at the scene are inhalation injuries and electrical injuries. So once patients make it to the hospital, their primary cause of death then is sepsis. So trauma always trumps burns from a standpoint of if it is a concomitant injury. The ninth criteria is any burns in children without qualified personnel or equipment. And the final criteria is any burn injury in patients who may require special social, emotional, or long-term rehab. When we think about burns, it can happen to anyone at any time. It crosses all socioeconomic levels, and these patients need treatment as quickly as possible. So initial assessment and management. With any burn patient, we want to overlook the burn. especially in smaller smaller emergency departments. Oftentimes things can be missed because the burn is very distracting. If you watch the crime TV, you'll know that fire is often used to cover up crime. So when a patient comes in and they are not able to tell us what happened or it wasn't witnessed, we have to assume that there is a trauma. So we have to rule that out before any of the burn injury is addressed. So every patient that comes in is treated the same, whether it's a trauma patient or a burn patient. It's airway, breathing, circulation, disability, and then exposure, making sure that we look everywhere on the patient. We want to make sure that we look between the fingers and between the toes. With your electrical injuries, you can have hidden injuries. Secondary survey is history and then your head to toe physical exam. The history is very important with these patients, especially if they're intubated prior to arrival at the emergency department or prior to arrival at the burn center. The history is going to give us a lot of information that we might not otherwise be able to get. And then, of course, your initial laboratory studies. Airway assessment, airway control. Of course, we're going to evaluate the airway. Always want to be sure that our airway is clear. If there's a suspected inhalation injury, we always say, when in doubt, intubate. We'd rather intubate somebody who doesn't need it than not intubate somebody who does need it. If there's any risk of trauma, then we, of course, want to maintain C-spine precautions. So breathing and ventilation, look, listen, and feel, making sure that we're administering 100% FiO2 for patients with any suspected inhalation injury. You want to monitor your chest wall excursion, especially in patients who have full thickness injuries. When the skin burns, it loses the elasticity in that stretch. So you can have the inability for chest wall excursion due to the full thickness injury. So about 2 to 14%, and if you look at the journals, they're very extremely varying numbers on what the consensus is of the number of inhalation injuries. But there's a recording of somewhere between 2 and 14% of all admissions have some type of inhalation injury. But they are pretty consistent with 60 to 70% of the patients who die have an inhalation injury. So looking at that, say inhalation injuries increase your mortality rate by up to 50%. So when we evaluate the inhalation injuries, we think about carbon monoxide poisoning, cyanide toxicity, excuse me, injury above the glottis, and injury below the glottis. Carbon monoxide poisoning is your #1 cause of death prior to arrival at the emergency department, and has the carbon monoxide or carboxyhemoglobin molecule has a 200 times greater affinity for hemoglobin. So with these patients, when you have a pulse ox on them, your oxygen saturation is low, not because your oxygen is in the blood. You still have oxygen in the bloodstream. It's just not getting to the cellular level. So your pulse ox is not going to be the definitive diagnosis for carbon monoxide poisoning. You want to get a carboxyhemoglobin level, and treatment for these patients, definitive treatment is hyperbaric oxygen, but the best thing you can do for these patients is 100% FiO2. So just your signs and symptoms of carbon monoxide poisoning, and this is mimicked in our cyanide toxicity, very similar signs and symptoms with elevated cyanide as well. Carbon monoxide poisoning, again, definitive treatment is hyperbarics, and that is if the facility has hyperbaric therapy and the patient is stable enough to undergo hyperbarics. Some facilities do not have hyperbarics, and then others are, if they're involved in a trauma, may not be stable enough to undergo dive. But your half-life of carbon monoxide or carboxyhemoglobin is 4 hours on room air. If you put 100% FiO2 on these patients, drops them down to an hour, and then patients that go into the chamber, their half-life of carboxyhemoglobin is less than 30 minutes. Recently, there has been more and more attention focused on cyanide toxicity. And we always have said over the years that carbon monoxide poisoning was the #1 cause of death. Well, as we're looking at cyanide toxicity and patients who are dead at the scene or found down at the scene, those patients have a correlated elevated cyanide level as well. So they're very often associated with each other, and some EMS services are beginning to deploy cyanide treatment on the scene with any patients who are down in a structure fire. So when we look at the treatment for cyanide toxicity, for carbon monoxide poisoning or an elevated carboxyhemoglobin level, treatment's 100% FiO2 or hyperbarics. For cyanide toxicity, your treatment is hydroxycobalamin, which is a big name for vitamin B12, and it's just a large dose. It's actually 5 grams is the initial dose and can be repeated a second time. Remember that B12 is renally excreted. With the hydroxycobalamin, when you draw it up, you'll notice that it is a red or a magenta color, and it will discolor the patient's urine. So don't be surprised if you see that. Remember also that B12 may not be compatible with many drugs that are given in the ICU and the ED, so we prefer that that's given in a dedicated line. Moving on to injury above the glottis, when you think about the upper airway, there's a lot of soft tissue in the upper airway. So when that upper airway is damaged, it can begin to swell, especially if a patient is under resuscitated. As that fluid is started, edema will develop. So beware if a patient comes in and has an airway injury and they have delayed treatment for a couple of hours, you may see some edema develop rapidly as that fluid resuscitation is started. Injury below the glottis is what we in burn world refer to as a true inhalation injury, when that patient has been exposed to either a chemical or prolonged smoke exposure, and they have inhaled all of those toxins down into their lower airway. So you think about not only a high heat injury, but also the toxins and the chemicals from the smoke that cause damage to the airway. Very significant, again, increases mortality by up to 50%. We sometimes have a honeymoon period of somewhere between 2 and 5 days before these patients begin to slough their mucosal lining and will develop plugs and start getting very, very sick, often going into ARDS. So just a picture from a bronchoscopy on admission, can see the soot in the airway, but the airway doesn't look that damaged from an erythema standpoint, but look at the following day. How much more edematous that airway is, as well as the damage, the redness, very significant. So aggressive pulmonary toilet is very important with these patients, as well as other treatments. Some facilities use nebulized heparin for inhalation injuries. That can be controversial depending upon what facilities and their physician preferences. But anticipating respiratory involvement is important, and the #1 cause of inhalation injury is being burned in an enclosed space. So we usually think about structure fires, but also think about any automobile accidents where a patient may have an inhalation injury. They may have been entrapped in a burning vehicle. Singed nasal hairs are a sign. Burns to the face, neck, or lips. Carbonaceous material in or around the mouth is a telltale sign. Hoarseness, stridor, and respiratory changes are late signs. So one of the most important things, again, goes back to that history, is what happened. Where was the patient? Were they in an enclosed space, or were they outside throwing gas on a trash fire? Those can be very different injuries, and patients who are outside probably may not have an inhalation injury. So watching those patients very closely and monitoring them for any respiratory compromise is important. And as I said earlier, our rule of thumb is when in doubt, intubate. Again, we'd rather have somebody intubated who may not need it and extubate them early versus not intubate somebody who does need it. and have significant complications from that. So moving beyond the airway and breathing, we get to circulation. Of course, monitoring blood pressure and pulse rate, skin color, those are all very important things, but it's important to remember with your blood pressure, patient's blood pressure may be falsely elevated because of pain. If you have 3 or 4 or 12 Kerlix or dressings around an extremity, external blood pressure monitoring may not be as accurate as an arterial line. So our bigger burn injuries almost always have invasive monitoring. Pulse rate, these patients, remember, have a huge catecholamine storm. They're in a hypermetabolic state for an extended period of time. They're in pain, so pulse rate may be elevated for multiple reasons. Skin color, we may be able to monitor it or evaluate it, but due to an injury, that skin color may be changed as well from any type of burn. IV access, preferably through non-burn tissue, but sometimes there's no non-burn tissue to go through. Please just make sure that that site has been extremely well cleaned. We don't want to introduce a central or bloodstream infection from an IV that is inserted through a burn area. And then circulatory status with any circumferentially burned injury is important, and monitoring pulses hourly with those patients. If an escharotomy or fasciotomy needs to be done, we want it to perform that early versus waiting later and having more tissue damage. We'll talk about that a little more later. So when we think about fluid resuscitation, it is definitely a moving target. It is not, there is not a single patient that it is exactly the same across the board. So this is something that these patients have to be monitored regularly. We trend numbers, and our goal of fluid resuscitation is to maintain tissue perfusion and organ function while avoiding the complications of over or under resuscitation. Historically, when we look at fluid resuscitation in the burn patients across the country, we did a really good job in the United States of over-resuscitating patients. We've got a great EMS system that responds and are there very quickly when they're evaluating patients, maybe needing to intubate a patient, dealing with the trauma. They are not necessarily able to sit down and calculate the cc per total body surface area that needs to be provided. So the American Burn Association actually came up about 5 years ago with a pre-hospital fluid protocol. And that is so patients don't end up just having fluids opened up wide open, because again, all of the studies from the burn journal showed that we in the United States were over-resuscitating patients. So for pre-hospital fluids, patients 5 years and under should start at 125 cc's an hour. Patients that are 6 to 13, 250 cc's per hour, and greater than 13 years, 500 cc's an hour. And again, that's to avoid patients having 1 liter or 2 liters infused in a short period of time. The Parkland formula is what is most commonly used to calculate fluid resuscitation. And we've said always 2 to 4 cc's of lactated ringers multiplied by the weight in kilograms, multiplied by the total body surface area burn. The first half of that goes over the first 8 hours from the time of injury. The next half goes over the next 16 hours. But what was happening is we were all, and I'm going to throw myself into the we were all, because I always started patients at 4 cc's an hour unless they had cardiac issues. Then we would start at 2 cc's an hour. So recommendations from the American Burn Association are now that we start adults at 2 cc's an hour, children that are under 14 years of age, 3 cc's an hour, and electrical injuries, 4 cc's an hour. So that 2 to 4 cc's of lactated ringers is going to be dependent upon their age and whether or not it's an electrical injury. So as an example, I took a referral just last night from South Georgia in a smaller hospital. Physician said that already calculated fluid resuscitation. They should be running at 580 cc's an hour. And I asked, well, did you calculate that at 4 cc's an hour? And his response was yes. And so if you wouldn't mind, we'll just go ahead and cut that in half due to the current recommendations from the American Burn Association. So though even these recommendations came out several years ago, that information still is not getting down into the hands of the EMS and emergency departments. So if you're taking notes, please write that formula down. I'm not going to spend a lot of time on the total body surface area. I think most of you are familiar with the rule of nines. You can use a patient's hand as 1% of their total body surface area. So if they have splattered areas, because most of our burn injuries are not nice cut and dry and linear lines, and all fall into the equal rule of nines. Kids, we need to remember that their heads are bigger, their legs are smaller. So there is a formula where you subtract 1% from the head and add 0.5% to each leg for each year over 1. I honestly can't tell you that I sit down and calculate that all out, but we do have a much more in-depth diagram that we use that's called a Lund and Browder chart that breaks down each area much more specifically. But this is just a starting point. Remember that fluid resuscitation is just a starting point. We're going to titrate up and down based on the patient's response. And one of the key indicators that we have is urine output. For adult patients, we want to see 30 to 50 cc's an hour. For high voltage electrical injuries with myoglobinuria, we want to see 75 to 100 cc's an hour. And then our kiddos, our patients that are actually greater, and that says less than 30 kilograms. I'm going to have them change that to greater than 30 kilograms. It's 1 cc per kg per hour. And children who weigh less than 30 kilograms is 0.5 cc's per kg per hour. So we know that our kidneys are our first major organ that our body begins to shunt blood away from. So that's why urine output is such a great indicator. But I will tell you that that's not the only indicator. Kids have what we refer to as obligatory urine output. So kiddos' kidneys work great. They continue to put out urine. You may have patients who are end-stage renal disease and aren't making urine. So we have to look at a lot of different numbers, and we're trending their blood pressure, we're trending their heart rate, we're trending lactate levels, we're trending hemoglobin, hematocrits. So there's all kinds of different numbers that we're trending. And primarily when we think about fluid resuscitation, it's for our patients who are greater than 20% total body surface area burn injury or a high voltage electrical burn. So just remember that it's an estimate. Patients who have electrical injuries can have injuries internally that we don't see. Patients with inhalation injuries have injury to their lungs, and that is more surface area that we cannot calculate into our formula. If we have a delay in resuscitation, or, I know that none of our patients are ever inebriated or high when they are burned. In fact, we usually say that their total body surface area is indirectly correlative to or inversely proportionate to their alcohol level. So these patients are already dehydrated to begin with, so they may need more fluid. And then our small children with small burns, they have more surface area per weight kilogram, so those patients may lose more from their tissue than adults do. So always remember that fluid resuscitation is not easy. It's, again, just a starting point. Moving through the algorithm, we think about airway, breathing, circulation, disability as our neurologic deficits. In ABLS, we use the acronym AVPU. So what's the response? Is a patient alert? Are they verbal? Do they respond to painful stimuli, or are they unresponsive? And if they're unresponsive or obtundant, then what is that attributed to? I had a patient that was transferred to us years ago from a level 1 trauma center, and they called one night and had a patient that was about a 99% total body surface area. This patient was extracted from a house fire, was down at the scene, was intubated at the scene, and asked, what's her carboxyhemoglobin? Expecting it to be over 40. Well, her carboxyhemoglobin actually was only 2. And so, of course, a bunch of bells go off and light bulbs go off in my head. And it's like, you've got to solve this problem. If she was down in a house fire, and her carboxy is only 2, why is she unresponsive if it's not related to carbon monoxide poisoning? Lo and behold, she actually had overdosed, and she was attempting to commit suicide, had overdosed, lit the house on fire, and by the time there was enough smoke for her to sustain an inhalation injury, she had already stopped breathing. So she wasn't inhaling all of the materials of combustion. So just remember that the pieces of the puzzle all have to fit together. And then according to ABLS, our next is exposure and environmental control. Remember, from an exposure standpoint, all the clothing and jewelry need to come off. We want to look everywhere with these patients, and then maintaining a patient's body temperature. With our bigger burn injuries, these patients cannot maintain their own temperature. They've lost their ability to regulate. And so we need to help keep them warm because they do get cold very quickly. I had a patient that came into me years ago that had temperature of 89 degrees when he got to us. So remember, those bigger burn injuries, we've got to keep them warm. And so if it's a bigger burn, we're often going to recommend just clean, dry, either Curlex or clean, dry sheets, and warming their IV fluids, and of course, warming the back of the ambulance or aircraft, whichever they're being transported in. Secondary survey, of course, follows the primary survey, and really thinking about this as your head to toe physical exam. We're looking everywhere, and as much history as we can get, again, is important for us. And then radiologic and laboratory studies are imperative as well. Patients who may have been involved in a trauma may need to have a PAN scan. If a patient is not able to tell you what happened, it wasn't witnessed, then again, we have to assume that there's a trauma. We want to rule that out before we focus our attention on the burn injury. Laboratory studies, things that are special for different types of burn injuries. With electrical injuries, of course, we're looking at our CPK as well as CKMB and other cardiac indicators. Also, we're looking at urine for myoglobin with our laboratory studies as well. Different chemical burns can cause differences and changes in our labs. In our bigger burn injuries, we're going to have some significant electrolyte imbalances. H&H, the patients are going to become heme concentrated. We may have, not usually early on, but shortly thereafter, some PT and PTT changes as well. So when we're evaluating the burn patient, remember that the physiologic response is directly correlative to the total body surface area. So the bigger the burn, the higher or the increased physiologic response. So keeping those patients warm, protecting them, your primary survey, your secondary survey, those are all very important things. And when we think about the treatment of the burn patient from the standpoint of pre-hospital and the emergency department, airway, breathing, circulation, fluid resuscitation, those are all very important things. And making sure that we understand what's going on with the patient from a standpoint of how did the injury occur, where was the patient, are we overlooking a trauma? Those are all indicators and things that we want to consider when treating these patients. Once we've taken care of them from the primary and secondary survey and the patient's been stabilized, and then we assess the burn injury. When we think about burns, there's first, second, third, and fourth degree burns. And those second degree burns we can break down into superficial, mid-dermal, and deep dermal, but we certainly don't expect anybody who doesn't take care of burns regularly to be able to do that by looking at them. There is actually no magic machines or tests that we can do with patients to tell us the exact depth of the burn injury. Believe me, there's been lots of different studies that look at measuring temperature and scans and blood flow in the tissue, and none of them are as accurate as a seasoned provider's visual inspection. So when we think about first degree burns, remember when you're calculating your fluid resuscitation, you don't calculate based on first-degree burn. You only calculate based on second and third-degree burns. So your first-degree burns like a sunburn, no blistering, and it affects only the epidermis. And this will heal independently, usually in 5 to 7 days. Second-degree burns are partial thickness burns. So first and second-degree burns are partial thickness. Third and fourth degree are full thickness, and you will hear those terms interchangeably. I often will say that first, second, third, and fourth degree burns is just a little more descriptive than partial and full thickness burns. So a second degree burn penetrates through the epidermis into the dermis, and you can have blistering, you can have skin sloughing. In general, second degree burns are moist, pink, and very painful. I've had patients come in and they say, well, I was told that because there is a burn or a blister that it is only a second degree burn. And I tell people that I have peeled off a lot of blisters to find a third degree burn underneath. So I always say if there is a blister, it means it's at least a second degree burn and not only a second degree burn. The third degree burns penetrate through the epidermis, through the dermis, into the subcutaneous tissue. Third degree burns can be varying in appearance. They can be charred, they can be leathery, they can be white and waxy. In general, second degree burns are not as painful as third degree burns are not as painful as second degree burns. In fact, some third degree burns may not have any pain at all, and that's because they're burned below the level of the nerve endings. Our skin regenerates by coming up through the appendages in the skin, the hair follicles, and spreading out. So if you're burned below the level of the hair follicle, the only way you can heal is by secondary intention or contraction. You're not going to form any new skin. So skin grafting is generally required for third degree burns in order to provide those patients with the best functional outcome. Fourth degree burns are burn injuries that extend through the skin, through the subcutaneous tissue, deep into the underlying muscle, tendon, and bone. These are patients where unfortunately we do sometimes see amputations. We can do different flaps and free flaps, rotational flaps, all of those things, but you've got to have good tissue surrounding it to work with. As you can see with these fingers, they're completely charred down to tendon and bone. They're not salvageable. Unfortunately, those fingers are going to require amputation. So some of the factors that influence the burn depth. With thermal injuries, we think about the temperature, the duration of contact, the dermal thickness, and the blood supply. And then remember that our young and older patients have thinner skin. So it doesn't take as much temperature to sustain the exact same skin may have a deeper injury in our young or old because it doesn't take as much time for the injury to occur. So looking at this gentleman, he actually had a second degree burn, and this is him after he is healed. So completely reepithelialized, minimal dyspigmentation, and that pigment may return to normal. Sun exposure can cause hyperpigmentation that is not reversible. So sunscreen is really important. My apologies. Categories of burn injuries. About 86% of what we see is thermal. About 3% of what we see is electrical. And about 3% of those injuries are chemical. So the number one injury, as we said earlier, in adults is flame. In children is scald injuries. And this is a patient who was involved in a house fire, and you can see charred, leathery, some areas of waxy, but there's skin disruption. And you can see the area, if you can see my cursor, where it's pink and not quite as deep up here, but you can see her hair is completely charred. Looking at this injury, you know that this is a long-term issue for this patient. This is not a quick, easy second degree burn that's going to be healed in a couple days. This is going to require significant surgery and then a rehabilitation for her. So some of the questions that we ask is, how did it occur? Did it occur outside or was it inside? Again, inside being that enclosed space. Did the clothing ignite? How long did it take to extinguish the flame? How was it extinguished? We have patients who will jump in ponds or a creek or a river, and you can imagine the bacteria that is there, that we want to treat that very early, knowing that those patients are going to have probably an infection from a waterborne bacteria. When we think about whether or not gasoline or other accelerants were used, once the skin is damaged, those accelerants, and even if the skin is not damaged, the accelerants are absorbed and can cause systemic organ failure from a liver or renal standpoint, as well as the fact that the accelerants burn hotter, and so they're often going to cause a deeper injury than if there was not an accelerant involved. Was there an explosion? Do we need to rule out trauma? Did the patient fall? Did they hit their head? Did they lose consciousness? All of those things are questions that we ask. Do the circumstances match the injury? Is it a child that we may have to consider whether or not there was child abuse? If there was a structure fire, was it a smoke-filled space? How did the patient escape? Did they jump? Did they jump out of a second or third story window? Do they have lacerations from glass? Was there a loss of consciousness at the scene? Were others killed at the scene or others died at the scene? Those are things that are important for us to know. So with motor vehicle accident, how badly was the car damaged? Was there a car fire? And were there other injuries? So the initial care of thermal burn injuries, we're going to cover with a clean, dry cloth or sheet or dressing, and no ice or cold water, because that constricts the blood vessels and can often cause that burn injury to progress. Room temperature water to stop the burning process on small injuries is completely appropriate for those patients. So this is a typical scald injury in a child. You would be surprised how many patients we have that pull ramen noodles off of a counter or out of the microwave, and those are spilled often down the side of their face or lower face and onto the shoulders and chest. So this is a second-degree burn. You can see these watery blisters, nice pink moist wound bed. And using skin substitutes on this is something that's going to decrease the need for dressing changes as well as decrease the pain. So when we look at scalds, how did it occur? What was the liquid? What was the temperature of the liquid? If it was tap water, if a patient was in a bathtub, what was the water heater set at? How much liquid was involved? Was it just a cup of coffee or was it the whole pot of coffee? Was the patient wearing clothes, and were the clothes involved? Did they hold that heat against the skin or were they quickly removed? And was the burned area cooled? So again, room temperature water initially cooling that area and then keeping the patient warm. So unfortunately with children, we have to think about abuse or neglect, as well as with our elderly patients. And even, you know, I say that, and we do have lots of abuse. I can't say lots. We have patients who we see not infrequently who are involved in abuse situations where they're either set on fire or have hot liquid thrown on them. So there's child abuse as well as elderly abuse and neglect, and then there is criminal activity with assault as well. So who was the patient with when it occurred? How quickly was medical care sought? Where did the burn occur? And again, does the story match the burn? And that's particularly important for our children and elderly, because they're not able to convey that story to us. So some of the hallmark signs of child abuse are definite lines of demarcation. You can see here, this is what we refer to as typical socks or stockings. And that is a line of demarcation. Kids don't get into the bathtub with both feet. If they put one foot in, it's hot, they pull it out. So this is a definite abuse type case. Other things that we think about are, again, are stories that don't match the burn, stories that change frequently. Those are some signs of child abuse that we need to investigate further. Circumferential burn injuries I alluded to earlier, and you think about this is an injury that is around an entire arm, leg, neck, chest. So again, when the skin burns, it loses that elasticity. So thinking about third spacing and burn fluid creep, as that fluid weeps out of the intravascular space into the extravascular space, the skin, once it has a deep second or third degree burn, doesn't have the elasticity that it had when it was not injured. So the fluid can collect underneath the burn or possibly eschar and cause compression to the blood vessels. So as that fluid weep increases and is prolonged, the more edema that develops compresses the blood vessels and cuts off the distal circulation. And that's how the compartment syndromes develop in a burn patient. So this actually was an 11-year-old child who poured a can of gas on a flame. You can see that deeply burned arm, and just looking at it, it looks tight and firm. It is not soft and malleable like our normal extremities are. So we've taken this child to the operating room to do escharotomies. He actually was awake, alert, and oriented when he came in, and his burn injury was isolated to this entire right upper extremity and shoulder. But the amount of edema that had developed was very, very significant. So as we make the incision, you can see the release of that pressure. That tissue pulls apart. It allows the blood vessels to expand and restore blood flow to the distal tissue. You always want to, you can see where this escharotomy along the wrist and across the dorsal aspect of the hand. We don't want to cause a tourniquet effect by stopping the escharotomy here and then starting up here. You always want to make sure that those lines actually cross over each other, not physically each other, but that they're not causing a tourniquet-like effect. This is a patient who actually was engulfed in a bonfire, very horrific injury. He had become inebriated and lost consciousness, and then was engulfed by the bonfire. You can see very, very deep injuries, and with just a single incision, how much pressure is released. So if you think about the thorax and the chest excursion, when you have that deep injury across or around the thorax and you don't have the chest excursion, then you couple that with tissues that are beginning to swell. What happens, patients are not able to be ventilated, peak inspiratory pressures go up, tidal volumes go down. So that's when we need to do escharotomies on these patients and release that pressure to allow full chest excursion, and the patient is then able to ventilate the patients. Electrical injuries are often referred to as the great masquerader. There can be significant damage done. This is a very typical, we see this usually one every 2 or 3 years, deep injury from biting a cord. But what type of electricity was it? What was the duration of contact? What was the estimated voltage? These patients are very often adults, most commonly, and very often they're linemen or electricians. So was CPR administered, and were we able to get these patients back? So looking at the pathophysiology of tissue damage from electrical injury, you have high resistance with bone and low resistance with nerve and blood vessel. So with the high resistance, you have friction, which increases the temperature internally. And you may have heard people say that electrical burn injuries cause damage from the inside out. And this is what they're referring to, is that friction with the more dense tissues such as the bone. So we're always looking for contact points, previously known as entrance and exit wounds, arc wounds, thermal wounds, and hidden wounds. Electricity has been documented to be up to 3,000 degrees Celsius as it exits the body. So you can have a thermal wound as well as an electrical injury. I'm not going to go through all of this initial treatment at the scene as we're coming up on our deadline of closing the presentation, but I wanted to share with you some of the pictures from this electrical injury. This is a 28-year-old lineman who was hit with 48,000 volts. And you can see in this area right here, this kind of purplish color. So there's it's different pathophysiology with electrical injuries than with thermal injuries. So significant internal damage, damage to the blood vessels, which causes progressive tissue death. You can see here in the antecubital region, 24 hours later, how much darker that tissue is. He ended up with a bilateral disarticulation. Thankfully, we have come a long way in this world with prosthetics. So think about with our electrical injuries, lethal dysrhythmias, vascular compromise, compartment syndromes, as well as renal dysfunction and failure. Those are some key things to think about if an electrical injury comes in. With chemical burns, we want to know what the agent was and how long was the exposure. Is there any eye involvement? The one thing that we can affect is the duration of contact. We want to get the chemical off of them as quickly as possible. These are just some common agents that we see. Hydrofluoric acid is actually neutralized with calcium gluconate, and that can be given topically as well as provided if it's on a hand intraarterially, or can actually be injected into those areas. Emergency care for any chemical injury is to brush off any chemical that's a powder. Again, exposure, everything needs to come off, and that patient needs to be irrigated. I want to show you these pictures just as a demonstration. This is actually one of a patient that we had many years ago, but very different in appearance than your thermal injury. You look at these legs, this is all 3rd degree burn. So this is that white and waxy in appearance. This cherry red, this is 3rd degree burn. So the appearance is very different than your thermal burn injuries. So excision of the devitalized tissue. These patients go into a severe catabolic state, and they can stay in that catabolic state for up to a year after their skin is healed. So we've gone from, let's see, where was that, to him? And granted, we've got some edema going on, but he wasn't a tiny guy to begin with. And this is him when he's healed. So very, very significant catabolism. And granted, this was one of our patients from many years ago, but we do start these patients very early and nutritional compensation as well as anabolic steroids. So I want to cover real quickly before we end some of the cutting edge treatments in burn care. Topical treatments are still around. They're still used in a lot of places and some different situations. But dermal regeneration templates can be used for those deeper injuries. Integra is one that is most commonly used by all burn centers across the country. And then looking at the Integra, again, a dermal regeneration template is kind of a matrix for a neodermis to form, and then a much thinner skin graft can be harvested to provide coverage. So this can be used in acute injuries as well as reconstruction. This was actually an electrical injury to the patient's scalp. The electricity was actually drawn to the little metal peg on the patient's baseball cap. You can see here, there's a dermal regeneration template here. Actually covered that with a vac to pull some of that blood supply there. You can't put a skin graft on bone. There's not enough blood supply to keep it alive. So here we are burring down that dead, damaged tissue and getting a little bit of bleeding, and then using that dermal regeneration template here. Amniotic membrane, we think about that is truly the amniotic sac from a birth. And looking at the United States, we actually harvest less than 1% of the live births in the United States. But this is hugely beneficial for our deep partial thickness injuries. As we progress with understanding different dressings as well as different skin substitutes, we will learn more and more and new ways to use these. These are also used not only in burn injuries, but in wounds as well. So it's been quite, it's made quite a difference in our deep partial thickness burns, especially on the face. See, this is actually after it's been on for approximately 3 days, dry and crusty, and this is him when he's healed 6 weeks later. Meek technique is actually not new, but we use it now in conjunction with different technologies to cover large burn areas. So it's where you take a small piece of skin and expand it, and these used to be called little pitch grafts, to cover a larger surface area. So you can see this, he has multiple areas on his back, but donor sites are smaller and we can cover larger areas. And that's required when we have large surface area burn injuries, because we don't have enough skin, healthy skin, to cover all of the burned area. And you can see just in this video the expansion of that small piece of skin and how much it covers. So a cultured epidermal autograft, or also known as CEA, is where we take a biopsy and send it to the company. They can then grow the patient's epidermis. Again, it's just the epidermis, so it has none of the dermal element, but we use this over wide meshed autografts or the patient's own skin to get coverage for our bigger burn injuries. RECELL, you guys may have heard of the skin gun. This is the only commercially available application at this time. And again, we use that over wide meshed autografts to heal our bigger burn injuries. Skin TE is a brand new technology that just beginning to be investigated in the burn world. Can't give you any input on it yet. Reconstruction, though, we follow these patients long term. That's one of the things that I love about burn patients, is that we follow them for an extended period and not only take care of their acute burn, but we perform their scar reconstruction as well. You'll remember this gentleman was the electrical injury to the scalp, and he had a concave area in his scalp because of the bony tissue that was damaged. We're able to put a tissue expander, stretch that healthy tissue. Neurosurgery came in with us and put a convex plate in, and then we were able to pull that healthy tissue over and close that defect, giving him back the convex contour of his scalp. This is a tissue expander here as well. Very significant injury to this face. She still has scars here, but I think we'll all agree, going from this to this is a very significant improvement. Another tissue expander and the chest of a young child. Thick hypertrophic scars. They're painful, they itch. And then we've gone from this to just that single incision line. Also, laser therapy is something that in the burn world is being used more and more. We've been able to use this for the past many years and seen significant improvements in our patients, not only the thickness and density of their scars, but also the color and pliability. Decreases the pain and itching significantly for patients and is much less invasive than the previous tissue expanders. So really it's come a very long way, and I'm so, like I said, I've been doing this for about 20 years, and the changes that have taken place, the patients that we are returning to functional lives now, is so different than when I first started taking care of these patients. So I know that we're only a few minutes left until closing. I would be happy to entertain any questions or answer any questions that you guys have.
Wow, Justin, that's great information. We had two questions about medications in the chat box. First was, what about vitamin B dosing in pediatric patients?
A great question. There are not studies that have been well performed, and if anyone wants to reach out to me directly, I can provide you with our pediatric intensivist information, and they dose that based on weight, and I don't have it on the top of my head, but it has not been well studied and is not being universally used. So I apologize for not having that on the tip of my tongue, but I'd be happy to share my contact information. My cell phone number is 706-829-5148, and my email is Jocelyn, JOCELYN, .hills, HILLS, @burncenters.com. that is plural.com. And I would be happy to get that information to you. Oh, Scott, I don't hear you.
Sorry. Second question was related to what effect does nebulized heparin have for treating?
For the inhalation injury, it helps to break down those casts. It's mixed with mucimus, and so it breaks down the casts that develop in the lungs from the sloughed tissue. And when we bronch those patients or we suction out those patients, it's much easier to clean those casts and the debris out of the lungs. And it also seems to have an anti-inflammatory effect.
Great. Another medication question. What's the current trends and what's your use of high dose vitamin C?
High dose vitamin C does have a role. In the 90s, it was studied in Japan. We used it in the early 2000s quite extensively. When the ABA made the changes to the recommendations for fluid resuscitation, we were seeing less over resuscitation now than we used to, though still a lot of over resuscitation. And vitamin C actually has quite a diuretic effect. And so if you're not real careful with vitamin C, you can actually dry those patients out a little too much. So there is still a role for it. We don't use it as much because we have dialed in our fluid resuscitation very, very specifically and have a nurse-driven protocol that allows for fluid titration every single hour. But the anti-inflammatory effect, the free radical scavenger effect of vitamin C is still used, though not as much as it previously was. Oh, I can't hear you, Scott.
Sorry. And Dr. Holmes from Wake Forest Baptist has a comment to make. Dr. Holmes, are you able to unmute yourself?
Yeah, can you hear me, Scott?
Yes, go ahead.
Thanks, Jocelyn. Hey, this is Jimmy Holmes, the director of the Burn Center at Wake Forest. And just to clarify some things with respect to the North Carolina burn system as coordinated through OEMS between us and the University of North Carolina Chapel Hill JC Burn Center. Augusta and the JMS Burn Center Doctors Hospital there is not the closest burn center to any point in North Carolina when accessed by road. Period. By line of flight or as a crow flies, yes, there are areas in Cherokee County in the far west that if you were going to fly somebody, it is in a direct line closer. But as accessed via road, which is how most burn patients are transported and are eminently stable for ground transport, Augusta is not the closest. Another thing, singed nasal hairs actually are not associated with inhalation injuries. And all of the studies that have looked at it, interestingly enough, singed nasal hairs have never stood up to analysis. Now, facial burns are definitely associated with inhalation injuries, but singed nasal hairs are not. And along those lines, with respect to intubation, I mean, I agree with Jocelyn that it's always better to have a secure airway than a dead patient. But on the flip side of that is, intubating a patient is not a free lunch. And in North Carolina, per all the OEMS protocols, as well as all of the different transport service protocols, there is no mandatory indication for intubation of a burn patient for transport via any mechanism just because they're a big burn. You need to meet the Denver criteria for intubation of a burn patient. But all in all, nice presentation, Jocelyn. And Scott, thank you for inviting us.
Great. Thank you, Dr. Holmes, for that clarification. Are there any other questions? We're a few minutes over, but these are great questions so far. All right, if not, feel free to contact Jocelyn. Her email is in the chat box. or you can email me or go to our website. The website is metrolinatrauma.org, and my email address is scott.wilson@atriumhealth.org. Thank you, everybody, for attending today.